A male patient who underwent parathyroidectomy and who also has a pancreatic mass. Can you define to me what is hyperplasia?
So hyperplasia is defined as the increase in number of cells in a tissue in response to either a stimulus or trauma.
All right, that's perfect. How many parathyroid glands are mostly affected in this patient?
So there are four parathyroid glands that would be affected, two inferior and two superior.
And what is the microscopic picture of hyperplasia?
So the microscopic picture of hyperplasia can be split into common and uncommon. The common would be predominantly chief cell hyperplasia, and then secondary would be that of water cells and clear cells. There's also an element of mild fibrosis as well, and oxyphil on hemolytic staining.
All right, that's really well done. And this patient developed this stupor and confusion and hypoglycemia. Could you please explain to me why?
Yes, so given the fact that the patient had a pancreatic mass and also parathyroid hyperplasia, this fits in situ with an insulinoma. And this would also correlate with the presenting symptoms of confusion and stupor as well.
Right, well done. What are the other causes of unresponsive hypoglycemia?
So the other causes of unresponsive hypoglycemia would be ectopic insulin production from a fibroma. Another example would be hereditary causes, such as inherited glucogenolysis, and then finally diffuse liver disease.
Right, well done. Sometimes you have abnormal insulin sensitivity as well, which I think you've touched base on that as well. All right, so talking about insulinoma, what is the clinical picture of insulinoma?
So insulinoma is based on a triad known as Whipple's triad. So this is where a patient will have hypoglycemia, which can also be induced by exercise, neurogenic symptoms such as stupor and confusion, and then following the administration of insulin, they have immediate release of or relief of symptoms.
After treating the hypoglycemia, yeah.
Yes.
And how would you diagnose insulinoma biochemically?
So biochemically, the first thing I would like to do is blood glucose monitoring 4 to 6 hourly. And then also you can measure the insulin level that can be determined by C-peptide. Other
Yeah.
things that you can also look at is the ratio between insulin and C-peptide as well.
I think the ratio is probably the most important because
Yes,
this is the most diagnostic thing.
yeah.
And also the insulin products or C-peptide and also pro-insulin, which can be measured as well. There are three gene mutations in insulinoma. Can you tell me what are these genes?
So the first one would be men type 1, so that's menin on chromosome 11. The second one is associated with mental retardation syndrome, so that's RTREX. And then the third one is PTEN and tumor suppressor gene 2. These are tumor suppressor genes that are associated with the mTOR pathway.
Right, perfect. Really well done. There was really nothing to add, so I really like that. Is there any other pathology that you might suspect in this patient?
So given the fact that this patient is likely to have insulinoma, which is associated with men type 1, the other syndromes that are associated with chromosome 11 and the autosomal dominant mutation of menin gene would be that of pituitary adenoma and pancreatic tumors and parathyroid adenoma. But here, the main one is pituitary adenoma.
All right, perfect. What is a double hit hypothesis?
So the double hit hypothesis is something that evolves around the tumor suppressor gene. So essentially what you need is a mutation in both tumor suppressor genes in order for the mutation to be expressed and loss of function. And this typically happens in that of autosomal recessive patients.
Well done. And what is a telomere?
So the S telomere is something that is in situ at the end of the chromosome. It's a repetitive nucleotide sequence that prevents the fusion of chromosomes that are in close proximity to each other.
All right, perfect. So it's a repetitive nucleotide sequence at the end of the chromosome. Well done. I think overall performance is perfect. It's definitely a pass. There is nothing really to add. You're very direct. You're giving me the answers straight away. There is no fillers that have been used at all. So I really like your answers. That was really well done.
Thank you.
I think I'll continue with you, Men 2, just for completion of Men syndrome, and then that will be it. All right. What is the single best test to do in a female patient with a thyroid nodule and elevated calcitonin level?
So here I'd like to do a fine needle aspiration and cytology and then immunohistochemistry.
And what is the type of cancer in this patient based on the pathology report? She had malignant cell features, amyloid deposits, The IHC stains positive for calcitonin and it stains negative for thyroxine. So what do you think of the type of cancer?
So here, given the patient's report of amyloid deposits, calcitonin being present, and amyloid deposits as well, I'd be strongly suggestive of that of medullary cell cancer associated from the parafollicular C cells.
Yeah, perfect. And why you explained why in your answer because of the amyloid deposits and calcitonin as well. And what's the cell source? What's the cell of origin for medullary thyroid cancer?
So the cell of origin would be parafollicular C cells.
And what is IHC in simple words?
So immunohistochemistry is a test that is used to localize specific antigens. So the antibodies are associated with an enzyme or a dye typically. And when they bind with the complex of the antigen, that activates the dye, and hence why you get it present on immunohistochemistry.
All right. So I think you sort of explained how does it work, not what it. You've done both basically. So it's a when you're being asked what is it, so it's a method to localize specific antigen in a tissue based on antigen antibody recognition. That's the definition of what is IHC. How does it work? It's exactly what you mentioned. So you want to identify this antigen by introducing some antibodies that are on an enzyme activation or on a fluorescent dye. And as soon as you have the antigen antibody complex coming together, the enzyme will be activated or the dye will appear. All right. And what is the type of antigen antibody reaction in IHC?
This would be that of fixation.
Perfect. And is this condition considered familial?
Yes, so if this condition was considered familial, I'd be suspected MEN type 2, and therefore I would be suspected of parathyroid hyperplasia and pheochromocytoma.
Perfect. And what are the, I mean, we have two different types of MEN syndrome, right? So can you tell me what are those types and what are the characteristics of each and what are the oncogenic mutation and the mode of inheritance?
Yes, so first of all, the three syndromes are autosomal dominant inheritance pattern. Then MEN type 1 is associated with menin gene on chromosome 11, and MEN type 2A and 2B are associated with that of RET oncogene, which are on chromosome 10. MEN type 1 is associated with insulinoma, so pancreatic tumours, parathyroid hyperplasia, and pituitary adenoma. Type 2 is associated with medullary thyroid carcinoma and pheochromocytoma. And then finally, MEN type 2B is associated with acoustic neuroma and marfanoid features.
I think you probably have missed one. I'm not sure if I missed you, but I think you probably have missed one in MEN2A. So it's calcitonin and pheochromocytoma and hyperparathyroidism as well. So the way I like to remember it, the 3P in MEN1 and the 3C in MEN2. The 3C in MEN2 is calcitonin and catecholamines. And you add at the end marfanoid features and mucosal neuroma, the 2M, with the MEN2B. So all of them are autosomal dominant. This is chromosome 11 was 1, and this is chromosome 10 was 2 and 2B. All right. How would you treat medullary thyroid carcinoma?
So for medullary thyroid carcinoma, I'd like to perform a total thyroidectomy with a block neck dissection or selective dissection.
All right, perfect. Sounds really good. All right, so I'm really amazed. Really well done. Your answers are very specific, to the point. You're not adding too much information, or you're not adding any fillers in your conversation. So you're just direct and to the point, and this is how the exam should be. So that honestly, this is a very good example for how to pass this exam, right?
I
Just
think
give a direct answer and try not to confuse yourself. All right.
your YouTube videos are very helpful, so thank you.
Oh, thank you very much. All right, can you guys hold the line 1 second? We have a patient who is going for bilateral nephrectomy due to intractable abdominal pain. You are presented by this picture after the nephrectomy, and you're being asked to talk about your growth pathology.
In this picture, this is an enlarged kidney, which is having a lot of cysts over its surface.
Right, that's fine. So it's an enlarged kidney with multiple cysts on both sides, and these cysts are black, fluid filled, and different sizes on both sides as well. This could represent polycystic kidney disease, but you need to do further tests. What's the mode of inheritance of polycystic kidney disease?
It is autosomal dominant.
And what's the pathogenesis of a cyst formation in this condition?
There is abnormal proliferation of the epithelial in the tubules, which ultimately leads to secular dilatation of the tubules, and then these tubules get separated from the main connecting system, and these get filled with the sodium chloride and the water, and these multiple cysts basically develop into a polycystic kidney disease.
That's right. So you're thinking about it in four steps. The first step is inactivation. Second step is out pocketing or out pouching. Third step is expansion, and then isolation and growth as the last step. So inactivation of the renal tubules, and this will start to divide repeatedly. Out pocketing will form a small pocket coming out from the wall, and then expansion, it will get bigger and start to be fluid filled. And then isolation at the end, it will completely isolate and basically form a cyst. What are other organs that could be involved in this condition?
It may develop in the liver, spleen, and GID.
So it could be multiple things, but most importantly, you're talking about liver and ovaries and pancreas and spleen as well. What are the complications in this condition?
It can get infected and get hemorrhage or hematoma.
Anything else?
Probably nothing in my mind.
I understand. So complications for this condition, most importantly, is renal failure, right? So yes, I agree. It can get infected and lead to pyelonephritis. If you want to use more scientific words, it could get infected and lead to pyelonephritis. Patient can get hypertension as well. But renal failure is probably the most important thing because all these patients end up having renal transplant at the end. This condition is also associated with a brain lesion or a brain type of pathology. What do you think this is?
It is medullary disease which can develop in the brain or
I see. So brain aneurysm is probably the most important thing to mention here. So cerebral aneurysm. And what are the types of matching in renal transplant?
these are ABO and HLA matching.
So it's an ABO and HLA matching. The HLA could be type B and type DR as well. What are the types of graft rejection that you?
It may be accelerated, acute, or chronic rejection.
Can you tell me specifics about these? And this include when does it happen?
Hyperacute usually develops immediately after releasing the clamp. Accelerated acute usually develops within days, and then acute is from few days to the 4 weeks. Sorry, acute is from 1 month to the 6 months, and chronic is after 6 months.
And what is the pathogenesis for each?
Hyperacute is mostly ABO compatibility, and it is antigen antibody mediated. And usually the accelerated acute is cell mediated. And this chronic is usually due to the infection, and it is because of type 2 reactions.
And what is the treatment for each?
I'm not sure.
So for the hyperacute, you will immediately remove kidney. And for acute, you can try high dose steroids. And if it's not responding, you will end up removing the kidney. And for chronic, again, you can try steroid, but if not, you will end up removing the kidney because this patient will end up in renal failure. Perfect. What is the type of malignancy for immunocompromised patients? Well, these are one of the things, but I think it's squamous cell carcinoma is probably the most important, and basal cell carcinoma with Kaposi sarcoma as well. All right. We have a 60-year-old female patient who presented with headache, skull tenderness on the temporal side, specifically during mastication. She also reported transient loss of vision. Temporal artery biopsy was taken later and revealed a giant cell arthritis. What is giant cell?
It's the inflammation of large and medium vessels.
What is giant cell arthritis?
It's an inflammatory disease of both medium and large blood vessels in the head. And then it causes symptoms like pain over the temporal area, flu-like symptoms, and loss of vision if left untreated.
Perfect. And which part of the vessel is mostly affected?
It's the internal elastic lamina of the tunica media.
So it's basically the intima and the media, but you're right in saying the internal elastic lamina of the media. What's the pathological change? So you will be given a picture, which is this one, and you'll be asked to describe the pathological changes that you can see.
There is intimal thickening or thickening of the intimal, leading to reduction in the diameter of the lamina. And then there are patchy infiltrations of lymphocytes, macrophages, and some other giant cells.
All right, that's fine. So basically, what you want to talk about is the intimal thickening. All right, the intimal is very thick, as you can see in the brown picture. There is some granulomatous inflammation in the wall of the intima as well. You can see lots of granulomatous tissue. And all of these blue stained area, these are granuloma. And there is some infiltrate of T cells, and T cells are usually CD4 and CD8. And I think these are the main points to mention. So thickening of the intima and narrowing of the lumen. What's the initial test you will do for this patient coming to your clinic or to your A&E?
Yes, sir.
ESR. And what is the best test to diagnose this condition?
Temporal artery biopsy.
Well done. And what is ESR?
It's erythrocyte sedimentation rate. So it basically just involves putting blood in a test tube and then looking at how fast the red blood cells sediment at the bottom of the tube.
Right. So can you tell me how is it done again?
So put it in a tube called, I don't remember the name of the tube at the moment, but then the tube is placed vertically in a tube rack and then left to sit for an hour. And so the rate at which, or the distance between the top of the all blood cells as well as the red blood cells itself is then measured, and then that gives the rate per hour.
So the tube is called Western Grain tube, so right? So it's called Western Grain CADS tube. You will put the blood sample inside this tube for about 1 hour and 2 hours in a vertical position in a dark room, and then you start measuring the sedimentation after 1 hour and after 2 hours and compare it with the standard. All right, and how does blindness happen in this condition?
Blindness happens due to affectation of the ophthalmic artery.
Can you tell me how does this happen?
So basically, there is an anterior ischemia in the ophthalmic artery itself, leading to optic neuropathy.
How does the ischemia in the ophthalmic artery happen?
From inflammation of the artery itself.
So the artery can be included as part of the inflammation. However, it's not. The commonest cause is actually a thrombus that comes from the temporal artery into the ophthalmic artery. All right. So
Okay.
that's why these patients, you would avoid giving them aspirin on early. You might need to give them aspirin if they get ophthalmic artery neuropathy. All right. And the condition is called anterior ischemic optic neuropathy. ION, anterior ischemic optic neuropathy. How would you treat this patient?
We would have to give. Wait, do you mean patients with the ophthalmic artery affectation or temporal arteritis in general?
I don't understand your question.
You said, how would I treat the patient? Is it patient with, okay, all right. So we basically treat them with high dose corticosteroids, and then patients who already have ophthalmic artery affectation would have to give them IV methylprednisolone as well as for a very long time. But then patients without it, we can give oral prednisolone.
All right. I didn't get anything from your answer, I'm afraid. So your answer is very not structured and not specific. So you will give methylprednisolone for a very long time. What is a very long time?
For
Is
about
it 2
2 years.
hours? 1
Yes.
year? 3 years? 5 months? I don't know. Do you want to be specific in your answer, please?
So we treat with high dose corticosteroids. So immediately this is diagnosed, we start with the oral prednisolone, and then that's 60 milligram per day. And if there is already affectation of the ophthalmic arteries, we treat it IV methylprednisolone for about 2 years.
All right, so that's fine. So basically, well done for saying this, but what you want to say as well, what you want to add to that is, if you're worried about the patient visual symptoms and you're suspecting giant cell arteritis, you would immediately give them prednisolone, 60 milligram per oral. That will have to be given immediately, all right? And if you're worried about their visual symptoms, yes, you're going to give IV methylprednisolone. And then you add to that, if the diagnosis is confirmed, this patient will need to be on steroids for long term, likely prednisolone. And for this to happen, we need to have a discussion with the patient about the side effects and the problems of the cortisone. All right. So this is a more structured answer for this question. All right. This scenario can actually continue with talking about steroids. What are the steroid side effects?
They could come down with osteoporosis, wound healing, infections due to immunosuppressions. Okay,
All right.
obesity.
That's
then-
fine.
Okay.
So this is the time that you start trying to say things randomly, trying to remember things from the book, trying to remember things that someone say to you about the side effects of steroids. It's really simple when you think about it in the way that I'm going to say now. Very simple. So think about looking at a human body. You have skin, you have muscle, you have subcutaneous tissue and fat, skin, subcutaneous tissue and fat, muscles, bone, nerves, blood vessels, internal organs. And in these internal organs, you have the heart and the hormones are the most important. So skin, steroids patient can get skin striae and delayed wound healing and increased risk of infection. So that's for the skin. Muscles, myopathy and muscle ache. Subcutaneous tissue and fat, redistribution of the subcutaneous tissue and fat, mainly the fat. You get truncal obesity and moon face. Bone, osteoporosis. Blood vessels, hypertension. Blood, you get a significant increase in the white blood cells, but they are not all functioning well. Hormones, they increase the resistance to insulin. That's why these patients are at risk of having diabetes. So if you think about it this way, you will always get the answer correct and very quick in the exam as well. All right. So I think you were doing very well until the last question. This is when you lost it. And you were trying to ask me a question, which I didn't understand. And then you suddenly just continued your answer and ignored the question. I think you have to maintain your professionalism speaking with the examiner. So if you ask a question, make sure your question is clear and don't just say, oh, that's fine. And then start answering the question. Just make sure you're maintaining your professionalism during speaking with the examiner, because this is being assessed. This is almost 1/3 of the mark. And that's what the people don't really understand. So in pathology and acute care and all the other knowledge areas, apart from anatomy, your professionalism is being assessed and it represents almost 1/3 of the mark. Right? And professionalisms include how you dress, how you communicate, and how you talk, and how clear is your language, and whether you're showing respect, understanding questions, acknowledging answers. So all of this is part of your professionalism. Thank you very much. You have a female patient presented after a road traffic accident. She is known to have sickle cell anemia, and she had a CT that showed temporal mass measuring about 3.8 centimeters. That was accidentally discovered. She doesn't complain of anything from her head. What is the definition of sickle cell anemia?
Sickle cell anemia is a hereditary hemoglobinopathy due to an autosomal recessive condition. This leads to the hemoglobin molecules called hemoglobin S, which distorts the shape of the red blood cell into sickle or crescent shapes.
And what are the complications of such condition?
So you have roughly 5 complications. The first is vaso-occlusive crisis, which causes bone pain or hand, foot, and mouth syndrome. Hand-foot syndrome, acute chest syndrome, brain strokes, or autosplenectomy. You can also get infections with encapsulated organisms, splenic sequestration due to the massive entrapment of the sickle cells in the spleen, leading to enlargement of the spleen, aplastic crisis if there's infection with the human paravirus B19, and chronic tissue damage, which involves the heart, the spleen, kidneys, and lungs.
Right, well done. So 5 crises or 5 problems that you can get. Vaso-occlusive crisis. And this is triggered by infection, dehydration, acidosis, and it leads to affecting a bone. That's painful syndrome, hand and feet syndrome. Lung, acute chest injury. Brain, stroke, spleen, autosplenectomy. Sequestration crisis, and this is a massive entrapment of sickle cells inside the spleen that can lead to rapid enlargement of the spleen, and this happens early on the disease, and that's why it can be presented in children. Aplastic crisis, this is when you lose all the blood products, and it can be triggered by infection of parvovirus B19. And chronic tissue hypoxia, this occurs due to organ damage, and there is increased susceptibility of infection with encapsulated organisms, like you said. What's the mechanism of autosplenectomy again?
So the autosplenectomy, you have the red blood cells due to their abnormal shape. They are entrapped in the vascular sinusoid that leads to obstruction of the vessels, and this will lead to infarction, which will then lead to necrosis. These repeated episodes of infarction will lead to shrinkage of the vessels, and this will form a fibrous splenic tissue. This will then be called autosplenectomy.
So mechanism of autosplenectomy is basically due to entrapment of the cells. So initially, like I said, it will lead to congestion, all right? So the size of the spleen can actually increase, but multiple trapping of RBCs inside the spleen This will lead to chronic erythrostasis. So the erythrocytes will be static in that area, and this can lead to infarction and fibrosis and progressive shrinkage of the spleen. What are the surgical relevance of sickle cell anemia?
Surgical relevance of the sickle cell disease, you have gallstones, avascular necrosis, autosplenectomy, myelitis, pulmonary hypertension, delayed wound healing, and anemic heart failure.
So I think the gallstones and autosplenectomy are the most important. You can also add avascular necrosis and osteomyelitis, pulmonary hypertension, and heart failure. Delayed wound healing, I'm quite unsure if this is one of the risks for sickle cell anemia. Why do you think this patient will be immunocompromised?
The patient will be immunocompromised due to the inability of the spleen to perform its function to trap organisms. So the autosplenectomy will increase the susceptibility of infections by encapsulated organisms like Neisseria meningitis, H. influenza, and Streptococcus pneumonia.
So mainly encapsulated organisms, like you said, encapsulated bacteria will be high risk. All right. I think overall, well done. Good performance. Cover the main areas. Speaking clearly and nicely. So that was really good overall. This scenario usually, for some reason, come with a brain tumor. So we're going to continue on the brain tumor with yourself as well. So can you divide to me what are the brain cells or the CNS cells?
The brain cells include the oligodendrocytes, neurons, the meningoceal cells, astrocytes, and
Right. So why don't we give it a good classification? So basically, the brain cell, the way I like to think about it, are divided into neurons and non-neurons, right? So the neuron, this is the classical thing that we starting from high school till now, but probably primary school as well. The neuron has the dendritis, or the dendritic cell body, and the axon, and the terminal axon, and the nodes of Ranvier in between, etc. So this is the neuron, right? And then you have non-neuronal cells. And this can be anything else, starting from oligodendrocytes, astrocytes, and ependymal cells. Those are the most three important cells in this area. The non-neuron, you can give it a further classification. It can be classified into microglia and macroglia. The macroglia are basically the macrophages of the brain. And the microglia are exactly what I mentioned, the oligodendrocyte, the astrocytes, and the ependymal cells, all right? You'll find here that I've mentioned multiple things, but it comes under the same classification, all right? What are the causes of brain tumor?
The causes of brain tumor include primary and secondary. The primary causes are due to astrocytomas, oligodendrocytomas, ependymomas, glioblastoma multiforme, medulloblastoma, meningioma, the acoustic neuroma, as well as if there's lymphatics involved, that lymphoma would be present as well on pituitary.
Yeah. And the secondary, such as the breast and lung and colon and melanoma, etc. All right. Well done. I think the question should have asked what are the types of brain tumor that you know, rather than the causes of brain tumor. That's fine. What's the clinical presentation for brain tumor?
Yeah, so the clinical presentation of the brain tumors would be, so the patient can present with headaches, possible visual abnormalities or vision loss, possibly also decrease in the GCS or change in the Glasgow Coma scale, also motor and sensory dysfunction.
Mainly, you're talking about there's a space occupying lesion inside the brain, and this can lead to increase of the ICP or the intracranial pressure, right? So having this in the brain, you can get all the type of symptoms, including headache, nausea, vomiting, dizziness, up to loss of consciousness, and up to going into coma, and up to death as well. All right. So you can get general signs and symptoms, and this will include headache, nausea, vomiting, etc. Location-related signs and symptoms. If this mass is big enough and causing any effect on the nearby structures, such as the cranial nerve or the visual field pathway, so it can lead to some symptoms and signs as well. All right. So, for example, frontal lobe, it can lead to frontal personality changes, and parietal lobe, it can lead to dysarthria and also motor deficits and also visual field effect as well. Pupillar edema, if it's causing hydrocephalus as well. Progressive focal neurological deficit, and this is diplopia, visual field, motor deficit, and cognitive and behavioral defect as well. All right. What if you leave a brain tumor untreated? What's going to happen?
Patient will die.
So that's the final outcome. Right to say that, but it will be better if you speak about this in a scientific manner, all right? So if you ask one of the public, a patient has brain tumor, what's going to happen to them if we don't treat it? You'll say they will die, right? But you have to say it differently as a doctor, basically. So we'll say an intracranial mass is at high risk of increasing the intracranial pressure. And with increased intracranial pressure, the patient might have brain herniation or conization, right? So the patient will start to cone or herniate, and this will eventually lead to death or coma than death. The biopsy was taken and they chose squamous cells. What do you think is going on?
This would be a metastatic lesion, sickle cell carcinoma from somewhere else in the body.
So there is no really squamous cells in the brain, so it's very likely it's going to be from somewhere else. It's likely to be metastasis, right? Squamous cell carcinoma is probably the most common, and we talked about just a minute ago. The squamous cell carcinoma usually comes in the skin and the orifices. Right, the patient had wound infection following the biopsy. What's the commonest organism for that? Staphylococcus. What do you discharge? Wound discharge showing glucose. What do you think is going on? So your patient has wound discharge. You took it, you sent it to the lab, and the lab is saying, "Well, I can see some glucose in that discharge content."
What this could mean?
CSF leak, spinal fluid leakage. So CSF leak, the CSF usually has glucose, and that's why if there is glucose in the tissue and sorry in the sample, very likely that it is CSF. Okay, fine. All right. You are presented by this picture. Patient had this mass or this lesion. Could you please present the findings on this image and tell me what's your top differential?
The lesion, there is barely whitish and central ulceration with the surrounding red tissue.
You didn't tell me what's your top differential.
The top differentiation, basal cell carcinoma and squamous cell carcinoma.
So the above lesion is showing a small ulcerated region, maybe measuring 3 and 3 centimeters or maybe 2 and 2. It depends how can you measure that. And there is central umbilication of that lesion with lots of granulation tissue and rolled in edges and surrounding telangiectasia. Why do you think the surrounding area is red?
Because of dilated blood vessels.
Telangiectasia. What's the most likely diagnosis? You said basal cell carcinoma and squamous cell carcinoma as the top differentials. However, this is likely basal cell carcinoma. You can also add to your differentials actinic keratosis and seborrheic keratosis and verruca vulgaris as well. What's the natural history of basal cell carcinoma?
The sun exposure, the person who have a long sun exposure, and I think this only I remember.
Right. Yeah. Did you study the basal cell carcinoma or not? Right.
But
So the next.
after the sun exposure and the basal cell carcinoma is slow growing, and it's local destructive, but it never invades the blood vessels, and it's almost always, although it is 95% curative, but may be recur, and also it is a slow growing condition.
All right. So basal natural history. So history of direct sun exposure. It happens in the exposed area. It's very slowly progressive tumor, locally destructive, and limited to the potential. There is no potential for metastasis, basically, and it never invades the surrounding blood vessels. All right. So in pathology report, you've been given the pathology report. What are your concerns when you're looking at that?
I concerned about two things. Actually, there is a microscope. A macro, I will see the size and thickness and the margin of the lesion. And in the microscope, I will see the type of cell and if there is any stain used.
You've given me the generic answer without actually saying what are your concerns in this basal cell carcinoma presentation.
I concern about the size of the tumor and the involvement, the margin, the thickness, and the ulceration, and also about the type of cell in the microscopic, and if there is any stain used, IHC.
Can do that. You can answer that in the exam, but I'm very unlikely that you will get the whole mark because you're basically seeing the generic answer. But the concerns for in pathology report for this patient, your main concern is you've removed the tumor, you've removed all of it. You want to make sure that you've got a complete or total resection. All right. So the way to do that is to look at the margins. So you want to look at the margins. That's full. Second of all, you want to get a diagnosis. And third of all, you want to get the depth of invasion as well. So depth of invasion and the marginal status are probably the most two important. You can always use the generic answer which I mentioned multiple times in my videos, but I think you have to be still specific. You can say the margin, the generic answer in detail, but I would also start, I would be concerned about the margin and the depth of invasion. However, I will look at the whole report, and this includes 1, 2, 3, 4, 5. How does basal cell carcinoma metastasize?
Lymphatic.
Does it actually metastasize?
Actually, it is locally.
So you said lymphatics. So it's a locally destructive tumor. It's almost never metastasized to any part of the body, but it's locally destructive tumor. How would you manage patient with deep margin involvement?
With re-excision.
And what's the treatment in general for basal cell carcinoma?
In general, I will do the surgically management. So I will do excision for the lesion, and I'm making sure there is a free margin. And there is also a lot of, if I will do the surgical excision, I will also maybe do the more microscopic surgery if it's not free margin.
Sorry, I really want to stop you here because I'm so sorry. But this is an example of what not to do in the exam. All right. So I started saying the treatment. I will do surgical treatment. First of all, there is lots of R sound that are being used. There's fillers that are being used, and then very non-confident words. So she said the first option is surgical, and I am going for the surgical option. I might do the more surgery. That's very non-confident answer. So in the exam, I would always avoid using the word might, or I would probably, I will think about, or I think the differential is. So try to know rather than think. Try to do rather than probably do.
Okay.
So treatment for basal cell carcinoma, I think I'm not going to torture you for the rest of the